Good afternoon, everyone. Please take your seats. We're going to start this first Win and Hot session at Eular 2019. And this is going to be on the new avenues of management of osteoarthritis and osteoporosis. I am Serge Ferrari from Geneva, Switzerland, and my co-chair and co-speaker is Dr. Francis Berenbaum from Paris in France. I need to apologize a little bit because, as you see, they realized we were not playing the piano, so they're going to keep moving the piano out of the stage as we start the session. I hope this will not disturb our speakers too much. So it's my pleasure to introduce Dr. Berenbaum, who is the head of the Department of Rheumatology at the University La Sorbonne in Paris, and who is going to give you the updates regarding WIN in osteoarthritis management. Questions will be taken at the end of each presentation. Thank you.
Thank you so much, Serge, for your introduction, and good afternoon. I'm very pleased to be here and speaking on the osteoarthritis management and what we have learned in the last, I would say, 2 years. And what I would like to deliver in the next 35 minutes is really to give you very simple messages and take-home messages about OA, the management, and I will just start with, these are my disclosures, I will just start with very striking messages about OA, about the prevalence, the severity, and so on. So the first one is that the take-home message is that the prevalence of OA is dramatically increasing. This is a fantastic study, recent study, looking at skeletons from people, I will not say patients, from people from the prehistorical time to our time, and looking at the prevalence of the knee OA in these skeletons. And as you can see here, the prevalence was 8% at the prehistorical time. It was 8% in the pre-industrial time, meaning up to the 1950. And since the 1950 to now, the prevalence is now 16%. And as you can see here on the right, is that this is true at any ages. And in this study, when they adjusted to the weight, not for the prehistorical area, because it was not possible to have the weight, but when they compared the pre-industrial time to now, they showed that there was a doubling of the prevalence. So there is really a huge increase in prevalence, even if there are many potential environmental factors, not only obesity, but maybe also other environmental factors that maybe we do not know yet that are involved in this increased prevalence. My second message is that it's not only prevalent, the burden also of OA is dramatically increasing. And when you look at the global burden of disease on this WHO data analysis from over 183 countries, the RMDs in terms of years lived with disability is now at the second place, and sometimes in other databases at the first place. So the burden of OA is really, really high, and so it's a big health, public health concern. My third take-home message is that OA is a fatal disease. We have now a lot of studies showing that when there is walking disability due to hip or knee OA, you increase the mortality, I would say, around 50%. This is not marginal. This is a very big increase in terms of mortality. Altogether, due to that, now the FDA has issued a guidance for industry about the endpoints for the development of drugs in last August, and in this draft, in this guidance, FDA recognizes that osteoarthritis can be a serious disease. This is very important. Why is it important? Because when FDA considered that a disease is a severe disease, a serious disease, then it means that it will facilitate the availability of drugs for patients with this disease. So we are now in the situation of seeing OA as a very big problem for the next years, and that we really need new drugs or new treatments, any treatments, non-pharmacological, pharmacological treatments for this field. And this is also due because the unmet needs are very, very high. We used to consider that the total knee replacement is the cure of the disease. We know now that around 20% of the patients having a total knee replacement will keep on having a long-term chronic pain. And this is a big problem because when there is this shift to chronic pain in this period after total knee replacement, we know now that in these patients, the opioid consumption is very high. And you know all the problems with the opioid prescriptions. So let's look at this case. A usual case. I'm sure that in your practice you see this woman very frequently. A 55-year female, 5-year history of right knee pain. She also had hand pain, hypertension, obesity, so a lot of comorbidities. She's a shoe store manager for 20 years, and so she has consulted her general practitioner because of this knee pain that increased over the past 6 months. The average daily pain is at 7 on a scale of 1 to 10, and she has more and more difficulties to work. Shorter days, fewer clients, the business is suffering, the work productivity is decreasing because of difficulty for squatting down, difficulty for standing up for long periods of time, household is complicated, she cooks less frequently, she has difficulties for cleaning up, and so on. And at the end, difficulty for sleeping and maybe some depression. So she tried non-pharmacological therapies. She sees physiotherapists 2 times a week. She takes up Tai Chi sessions. She has some improvement, thanks to that, in flexibility. She has some decrease in knee pain. She took some NSAIDs, but on topic, because she didn't tolerate NSAIDs and the other weak opioids and so. So, based on this case, what can be recommended if we base the treatment on recommendations? She has chronic pain despite multimodal treatment. The pain affects physical, mental, and social functioning, and so she can no longer cope in her daily life. If you look at the recommendation, and if we try to find something common among all these recommendations, what is very important to note is that the non-pharmacological treatments are the core of the treatment today of OA. It could be weight loss, diet, it is always physical activity, it is walking aid if needed, maybe you can try thermal modalities. What is very important to keep in mind is that the non-pharmacological strategies are in the core of the treatment. I like this poster showed at the last ORC meeting, which was no new trials on exercise are needed in knee OA. I would say I tweeted this poster, and the newspaper Le Monde called me and said, oh, what's it, what that? And they did an article on that. It is not known in the public that physical activity is very, very important. And it is very well demonstrated that for knee OA, physical activity and exercise are important. and I just show you the last Eular recommendations for physical activity and exercise in people with arthritis. So these are the overarching principles, that the physical activity is part of a general concept to optimize health-related quality of life, that physical activity has health benefits for people with RMDs. The general physical activity recommendations include the 4 domains: cardiorespiratory fitness, muscle strength, flexibility, and neuromotor performance. And the planning of physical activity requires a shared decision between healthcare providers and people with RMDs. So now what about the pharmacological treatment? I'm sure you are aware of the possibilities we have, or we do not have yet, not anymore. First, acetaminophen, paracetamol. Second, NSAIDs. And third, when there are refractory symptoms, tramadol or opioids. Opioids, we now know that the benefit risk is very low. The benefit is not so high, and this is mainly due because you cannot increase the dosage due to the side effects that could be very, very severe. So, and of course we have the intra-articular treatments like steroids that can decrease pain during flares. So, unfortunately, the last messages we have from the literature in the last 1 year or 2 years are not so good. The first is this one from the Cochrane, is that despite guidelines for the treatment of non-traumatic knee complaints recommending paracetamol as a first choice analgesic in treating pain due to OA, this updated review confirms previous findings that paracetamol provides minimal, probably clinically unimportant benefits in the immediate and short term for people with hip or knee OA. So, efficacy, we have now paracetamol much below. Second message are safety message that are not so good also. The first one is about diclofenac. We already have a couple of studies that previously shown that diclofenac has some cardiovascular problems, maybe more for the long-term use and in patients who already have cardiovascular problems. This very recent publication in the BMJ showed that that diclofenac could also be deleterious for the heart and for the vessels, even if it is given for a short period of time. This is based on a very original study in terms of methodology, because it's emulated trials based in a nationwide registry. And so you can now, with very sophisticated methods, do clinical trials, which are, I would say, virtual clinical trials, inside a registry or a cohort. And this is based on this kind of methodology. And so it's in a Danish registry, and they look at, they perform, I would say, emulated trial in more than 250 periods. Each period is 30 days, and you see the numbers they were able to include. Of course, it's a big Danish registry. And the objective was to look at the risk of the major cardiovascular events of diclofenac within 30 days of initiation compared to the other NSAIDs, or compared to paracetamol, or compared to nothing. And here are the results. Unfortunately, there is an increase even for this short period of time. And this is true not only for the high dose, but also for the low dose when you compare diclofenac to NSAID, or to paracetamol, or to ibuprofen, or to naproxen. This is around 20 to 80% increase of these major adverse cardiovascular events. So this is the first message and red signal, I would say, for diclofenac. The second is about tramadol. So it's in the JAMA a couple of weeks ago, and showing that the use of Tramadol is associated with an increased mortality in patients with osteoarthritis. So this is based on data coming from general practitioners in UK, around 11 million of people in this database. And they look at the mortality in the OA patient during the period you see here on the slide. Of course, they adjusted for many, many variables with the propensity score. I have not time to give you all the variables they adjusted on. And you see the numbers and the assessed, the annualized mortality. Interestingly, you can look at the prescription prevalence over time for the last 15 years or 20 years, and you can see the dramatic drop of Diclofenac, the increase of naproxen in parallel. This is due to the previous studies I already tell you on the CV problems for long-term use. And you see this increase of prescription of Tramadol. This is very, very striking here on this slide. So the results are here. So there is an increased risk, an association of a higher rate of mortality over 1 year of follow-up compared to naproxen, 70% increase, diclofenac, around 90% increase, celecoxib, 70% increase, but no difference with codeine. So, of course, association does not mean causality. Once again, this is very important to keep that in mind. Association is not causality. But there is a signal here that should lead to having more precision on what happened here. So, now all together, we have less drugs, maybe we can give more hugs, but this is really a problem. Less and less drugs. The only way to compass this problem is to increase the innovation in the field. This is the only way. And we know that very well with rheumatoid arthritis. On the left, it's because we know the pathophysiology of the disease much better than 12, 20 years or 30 years ago, that now we have so many possibilities, even if we have not cured the disease. But now we are able to put patients in remission. The only way for OA is to also have this kind of opportunities for treating, is by the innovation. So we know also now more and more about the pathophysiology of OA, that the reason why now we have new targets in the field, I will not be able to give you, okay, today, to tell you we have now the target, we now have the drug, but we are now in the same process as 20 years ago for rheumatoid arthritis. So we really do hope that we will have these possibilities in the next years. So what do we have for structure, for example, as targets? We can increase the anabolism, increase the cartilage repair, in theory, or decrease the catabolism. These are the two ways we can think on. So what do we have as target for decreasing the catabolism? The one which is well advanced in the development is the low-risk CV-Wnt, which is a Wnt inhibitor for osteoarthritis. It's by injection, intra-articular injection, and it is based on inhibiting a signaling pathways that have been shown in many, many publications, many original papers, many experimental papers, that this is a very important signaling pathways that lead to cartilage degradation and also to bone remodeling. And so targeting this way makes sense due to that. And I will not go into the details of the preliminary results, I would say, like this one as a phase 2b in patients with knee OA with a Kellgren neurons 2 to 3 with a single intra-articular injection. And so the main objective was, of course, to look at some signals of efficacy, but also to look at the safety, which was there. And as you can see on the right, is that there are very interesting signals on favoring this compound. A second one is a Cationic Kay inhibitor, which is in development from Medivir, and there is this recent presentation by Phil Conagan at the ACR looking at the effect of this drug. It's an oral drug with different dosages, and there are some interesting data showing that there is some reducing in the bone area and in the cartilage thickness in terms of remodeling and of cartilage, on loss of cartilage thickness. So this is also very interesting. Yeah, what I've not said on this slide is that what I'm showing here is some pain signals, but they also have some interesting data on structure. So as you can see here, we have spoken on this one, on also this one, Wnt signaling, but you see that there are also other targets that are now on experimental studies in humans as ADAMTS inhibitors or other Wnt signaling inhibitors. Another way to impact catabolism is to impact inflammation, because we know that, and we do know that in rheumatoid arthritis, this is also the case in osteoarthritis. If you have more pro-inflammatory cytokines, you will induce the activation of cells that will release more proteinases and so more catabolic factors. So at the end, acting on inflammation should act also on catabolism. And what do we have in the last years? As you know, and maybe as you remember, the last attempt to target inflammation, to target cytokines, was not so effective. Unfortunately, the last cytokine inhibitor, which is an IL-1 alpha beta inhibitor, lutikizumab, was not successful neither in hand OA and in knee OA. On the left it's in hand OA, and on the right it's just published last week in the last issue of Arthritis and Rheumatology. So even if we today do not have the target for inflammation, it keeps on being very interesting, because once again we know that inflammation is linked to degradation, but maybe the cytokines that have been targeted until today are not the right ones. So we will still see other targets based on cytokines in order to have an effect on structure in the next years. Enhancing anabolism and cartilage repair. So we have one which is well advanced in development, which is sprifamine. Sprifamine is a growth factor, so it's a biotherapy. It's fibroblast growth factor number 18. And this can be injected into the joints, and there are some there are some animal data showing that with this drug, with this biodrug, there is an effect on cartilage by increasing anabolism. So I will just show you this trial, which is ongoing. It's a 5-year phase 2 trial with injection, as you see here, 3 injections per week for different period of time. So you see the different arms. And some results have been presented at the ACR by Mark Hochberg, and this is based on the 2 years data. The primary endpoint being structure on MRI. So the change in the total tibiofemoral joint cartilage thickness from baseline to year 2. And the results are encouraging on this level of structure. So what we are now waiting is whether there is also an effect on pain, and we will see that after this period of 5 years. Because, of course, in order to have today a disease-modifying osteoarthritis drugs, what is required is not only to see an effect on structure, but it is also based on seeing an effect on pain. This is mandatory now based on the last guidelines from the FDA. So, concerning anabolism, you see here the prefermin, the growth factors. But there are also other targets, and you know, or everything that is coming up now in the field of regenerative therapies and the mesenchymal stem cells. So the mesenchymal stem cells are cells that are undifferentiated, but are able to be differentiated in different cell types. And in a specific environment, these cells can be differentiated into chondrocytes. And that's the basis, initially, of using these mesenchymal stem cells for regenerative therapies like the OA. And I do not know why I'm speaking on that today, because we already have the clinics that are using mesenchymal stem cells. This is the miracle for treating this disease, if we consider that advertisement are science. The problem is that we should be very cautious on that, because when you look at the clinical efficacy now based on the experimental studies, the science, I would say, then the preliminary effect is 6 millimeters on VAS between 0 to 100. So maybe there is something, maybe there is an effect, and maybe this is very interesting. Maybe not due to the regeneration of the cartilage, but maybe due to the fact that these cells are able to release very interesting and important anti-inflammatory and anti-catabolic mediators, rather than being able to be differentiated into chondrocytes to form cartilage. So maybe the reason why it could be effective is not by the differentiation reason, but maybe by the fact that there is this release of interesting mediators. And what we need is very good trials. And as an example, there is one European trial which is called ADIPOA2, in which we are involved in order to see whether, based on very strict and very accurate methodology, there is an effect or not, and there is a placebo effect also. Okay, so before going to a clinic to have this kind of treatment, I think we have to wait to see the results of such trials. And I will close my talk with pain, because, of course, what we need is disease modifying. But before that, if we can have a very effective pain relief drug, this would be a first milestone. And as for disease modifying, what we need is to have a good understanding on the pathophysiology of pain. And that's what we are now, is that we know much more on the pathophysiology of OA, on the pathophysiology of pain compared to decades ago. And as an example, NGF is one of these targets, and why I am speaking on that target is because now we are in the phase 3 studies for that. So we know more on the pathophysiology. I will not go into the details. We know that there are the nociceptive pain, the neuropathic pain, the hypersensitivity pain. We know that for osteoarthritis, it is mainly nociceptive pain, even if in a subgroup of patients there is also neuropathic pain, and obviously also some hypersensitivity. But the anti-NGF drug has been developed for nociceptive pain because it has been demonstrated that NGF, nerve growth factors, is released when there is an injury into the joint, and by targeting NGF, you can expect decreasing the pain. And as you can see here on this meta-analysis, it's the first time that we see for an analgesic drug such an effect compared to NSAIDs, and based on what I have shown to you about the safety signals and the lack of efficacy of paracetamol, it is very important to have new drugs in the field. The concern with this drug is that there is also a safety issue, which is rapid progressive osteoarthritis. And this is seen in a low percentage of patients, between 1% to 3% of the patients. But of course, this is an issue because we are speaking about treating patients with OA. This drug was on hold by the FDA in 2010, and in order to understand what happened, and a mitigation plan has been implemented with the contraindication to associate, to co-prescribe this drug with NSAID to decrease the dosage, and based on that, the risk of this kind of safety issues has decreased. But we will see in the next months whether this will be sufficient for the benefit-risk ratio, and also to see in which patients this kind of drugs can be given, since it is a biotherapy by injection every 8 weeks. So I will close my talk with this slide, just to tell you that now that we are in the time of targeted therapies, it means that maybe we also have to get a better understanding of the phenotype of the patients. All patients with knee OA are not the same. We cannot compare a patient with a trauma OA with a patient with an obesity-related OA, for example. This is very simple phenotyping. But also, we now are in the field of endotypes, meaning that maybe in the future we will be able to phenotype the patient according to specific biological pathways. So this is a fascinating time, and I do hope that in the next years I will be able to present to you the results of the new drugs in the field, like for rheumatoid arthritis. Thank you very much for your attention.
So thank you very much, Francis, for this outstanding review of what's new in OA. And we have time for questions. Microphone 3 on the left.
Mark Felder, Switzerland. You said that 20% of patients after knee replacement have chronic pain. Is there a difference to patients with hip replacement, and why is that so?
Yeah, so that's a very good question. There is a big difference. For hip OA, this risk is very low. It's around 5%. So it's really for the knee OA. The reasons are not well known. So there are now some studies looking at these risk factors leading to this chronic pain, and mainly looking at what are the phenotypes of the patients before the total knee replacement that could explain why there is then the chronic pain. So, for example, we know that catastrophizing is one risk factor. There are other reasons that could be the high level of pain, maybe the severity of the degradation on X-rays. There are some reasons for that maybe, but we do not know why between hip OA and knee OA there is this difference. That's a very, very good question. Maybe it's something around also this nociception which could be higher for hip compared to knee. That's a very good question.
Microphone 2 in the middle.
Thank you. Branko Barac, Belgrade, Serbia. Thank you, Professor Francis, for a brilliant presentation. I just want to ask you a comment about some new treatment, especially, for example, cellular matrix is a fixed combination of platelet-rich plasma and hyaluronic acid. We conduct some prospective studies in Serbia and find very encouraging results comparing with two best HI that we found on the market, especially in all the scores, WOMAC, IKDC, KSS, VAS, and even, in the end, we find the thickening of the cartilage. Unfortunately, we measure by ultrasound. After that, one French group, I think it's guided by Professor Jean-Marc, find in a French pilot study also thickening of the cartilage with people treated with fixed combination of platelet-rich plasma and hyaluronic acid and osteoarthritis on the knee on the MRI. And what's your opinion about that kind of treatment?
Yeah, so there are many studies now looking at the effect of PRPs. It's quite comparable to what happened in the field of mesenchymal stem cells, for example, meaning that we already have this possibility to treat our patient with PRP, even if we do not have the quality of the trials in order to be sure that there is an effect compared to placebo. We have to keep in mind that the placebo effect in OA is very, very high, very, very high. And so finding something over the placebo effect is a big challenge. So for the PRPs, for association of PRPs and hyaluronic acid, for all that, it's an opportunity. This is a potential possibilities, but what we need are the best trials with the best methodology, with comparison, with saline injection, and by this way we will have possibility to have definite answers on that.
Thank you for answer. I invited you on poster session to discuss about the results about our studies. Thank you.
Microphone 1 to the right.
Hamad Murtada from Egypt. Thank you for a nice presentation. I want to ask, is there any agreement about the indication for surgery? When to send the patient for total knee replacement, for example? Second question is, there is parameters for activity of knee arthritis as in rheumatoid arthritis, or just we use the visual analog scale for pain and function? Thank you.
So for the second question first, yeah, we do not have the DAS28 as for the rheumatoid arthritis, but what we have are some composite of pain and function. You are all aware of the WOMAC, because the WOMAC is what you see in all the studies, which is quite impossible to use in practice, in clinical practice. So I will just give you my own experience, is that I use something else which is the Lequen index, even for the hip or for the knee. First, because you have a free app on your phone, and second is because it's very easy to use, and you ask the question, and then you have a certain level of activity. It's not really activity; it's a level of the handicap due to the disease. But because of the fact that we do not have also biomarkers that could help to design such an index, today we do not have that. Your first question is about consensus on total joint replacement for surgery. Very, very good question. There is no consensus today. We know that the optimal person to be operated with a knee OA is the one who has a certain level of pain and who has an evolution in the structural degradation. Today it is mainly based on X-rays. We would prefer, of course, more sensitive imaging like MRI. So maybe tomorrow we will use MRI for that, but today it's not yet the case. But there is no consensus. So that's really what we need. It's a consensus on that.
Microphone 3, short questions, short answers, please, because we're approaching the term of this talk.
Thank you for your presentation. And only one question: what about neuropathic pain, and what about the mechanism of neuropathic pain in patients with osteoarthritis?
Yeah. So in a short response, this will be very, very difficult. However, the neuropathic pain, in a way, is not different to what is already known for neuropathic pain for other reasons. It is quite the same processes. So there are some increase in the sensitivity also. The mechanisms are quite the same when we speak on the neuropathic pain of OA compared to what we already know for the neuropathic pain for other nociceptive related diseases.
Last question, microphone 1.
Thank you so much. With the treatment with analgesics and anti-inflammatories, we don't change the natural history of disease, and only increase the risks with these drugs. Is this correct? What is your point of view?
So, if I have well understood your question, you mean that by acting on pain, you will not have any effect on structure, and even maybe you have a deleterious effect on structure. Is it your question, your point?
Yes, it's correct.
Okay. So, it's not so easy to answer your question. First, of course, we know that when we target pain, in some, with the drugs we already know, we already have on the market, there is no effect on structure. Okay, so this is well known. And what is one hypothesis is that if the effect of pain is too good, then you are increasing the risk of structural deterioration because you will walk on your joint, which, so this is one hypothesis. However, until today, we do not have the studies that show that this is true. So I think that today, one objective is to decrease pain for our patients.
Thank you again, Dr. Birnbaum.
Now it's my great pleasure to introduce Serge Ferrari. Serge is at the head of Bone and Disease Department in Geneva, in Switzerland, and he will be speaking on how to treat osteoporosis in 2019.
Thank you, and so good afternoon again. So we'll switch from one chronic disease to another, which is osteoporosis, and this is my disclosures. Now, these are the questions I'd like to tackle with you today, which is where do we stand in terms of who to treat and how to treat osteoporosis, and we'll treat them as a set. The second set will be how long to treat and how to monitor the effects of therapy. And the last question, which has been an emerging new data, is whether there are other benefits besides preventing fractures of treating osteoporosis. Now, I'm not going to give you here a lecture of 30 years history of osteoporosis therapy. I would really focus on the last year publications that have brought some new concepts in the answer to these questions. So who to treat? Well, this is extensively discussed in a paper that is called the European Guidance for Diagnosis and Management of Osteoporosis in Postmenopausal Women. This is a joint paper that is revised every couple of years by the major European and international societies for osteoporosis. And in their January issue of this guidance, they very clearly define how to identify patients that deserve therapy. And this is by a combination of clinical risk factors and bone density assessment, so that patients who have clear clinical risk factors for fragility fractures, and it will be mainly existing major osteoporotic fractures or a combination of factors that, when used into this FRAX algorithm, give a high 10-year probability of fracture. Those patients need to be treated even irrespectively of bone density. For those, though, in the intermediate risk range, then they would need to have a DEXA, and if the bone density is also low, typically below -2.5 T-score at spinal hip, then they could eventually enter in the high category and be treated. Now, this simple approach has been very much challenged last year by evidence that treating women at intermediate low risk would also be beneficial. And this is the study of Ian Reed, who has randomized 2,000 postmenopausal women, average age 70, at low risk because their bone density was not osteoporotic, but barely osteopenic, and very few had previous fractures. And by treating them every 18 months with a single infusion of zoledronic acid for 6 years, he found a very clear reduction of first fragility fractures and specifically of non-vertebral fragility fractures compared to placebo. Now, if one considers that a treatment with zoledronic acid, which is now generic in most countries, costs about 10 euros per year, this is an extremely low cost for primary prevention, even in women who would not necessarily be indicated for therapy according to the European guidance. Going further, they recently published a subgroup analysis, post-hoc analysis in different risk groups, and I just want to indicate that what the arrows show, that even in the younger strata, there was a clear decrease in fracture with zoledronic acid. In women without previous fractures, there was a clear decrease, so low-risk women. And in those with hip T-scores, even above -1.5 T-score, which is virtually normal, there was a significant decrease in the incidence of new fractures. Furthermore, when they stratify by FRAX, they show that the benefits of therapy occur across the range of baseline fracture probabilities, even for women with fracture risk below 10% at 10 years, there still was a benefit. So this is a real new opportunity and challenge for us that would lead us to reconsider zoledronic acid every 18 months as primary prevention in a very large stratum of the population. But let's go back to the algorithm and focus on those who need most the therapy, which are those at high risk. Now, high risk is mostly defined by a prevalent fragility fracture, particularly a major osteoporotic fracture of the vertebrae or the hip, and even perhaps of other sites like pelvis or humerus. Now, what has been emerging since a couple of years now is the concept that among women at high risk, there is a subcategory at super high risk, and these are women that we now call to be at imminent fracture risk. And those are imminent fracture risk are mostly women with a recent fragility fracture. So this is Medicare data in the US, women above 65, very large number of women. And what you look here at is the proportion of these women who had a new fracture within 2 years after the index fracture. So women who had a spine fracture, a vertebral crush fracture, 25% of them refractured within a couple of years. 15 to 20% of women with a pelvis fracture refractures in a couple of years. 15% of those with a hip fracture refracture in a couple of years, etc. So there is sort of an emergency to introduce a therapy, not just in women at high risk because they have a prevalent fracture, but particularly in women with a recent one. And then there is a fantastic perspective that has been recently published in which the authors calculated the benefits of our current and future therapies if you consider the risk of women by FRAX, or if you consider their risk as being imminent because of the recent fracture. And what they showed here was that the number of major osteoporotic fractures that you would avoid by introducing standard alendronate or denosumab or teriparatide, or in the future romosozumab, which I'll speak about later, the number of fractures you would spare is nearly twice as much, nearly doubles, if you treat women at imminent risk as compared to considering women who are just at high risk with a 10-year probability calculation by FRAX. Now, what is the evidence that treating women with a recent fracture actually decreases the risk of fracture within a couple of years? Well, this is the old evidence, which was the only study actually that has enrolled women with a recent fracture. These were women enrolled after a hip fracture and who receives hyaluronic acid once a year, starting within 3 months after the index fracture. And that study clearly showed that by treating early in this very high-risk group, there was a 35% reduction in the second fracture within a couple of years. Now, much more recently, a subgroup analysis from the FREEDOM trial, which was a trial of denosumab versus placebo, Kendler published this analysis whereby they followed women who in the course of the trial had a fracture. And he looked at whether those who stayed on placebo or stayed on the drug for either 3 years or then in the extension stayed on the year for 10 years, had a reduction in fractures. And yes, they had. So this is now the second evidence that when you have a recent fracture, even on a drug, to stay on that drug will lead to continuous benefits in terms of fracture risk reduction. Now, I've been talking about anti-resorptives, hyaluronic acid and denosumab, in the context of the super high imminent risk. But a couple of years ago, there was this prominent study that compared teriparatide, the bone-forming drug, with risedronate in women at high risk. So these women were at high risk because they were recruited on the base of 1 severe or 2 moderate vertebral fractures. In addition to that, a third of the women recruited had actually a recent vertebral fracture and therefore would qualify as being at imminent risk. And 10% of them were on glucocorticoids, which is another factor for imminent fracture risk. And the results, as you know, showed a very clear benefit of treating these high-risk women with a bone-forming drug compared to risedronate, because teriparatide reduced vertebral and clinical fractures by 50% more compared to the standard bisphosphonate, which by itself is already efficient. And as in the previous studies, the authors then went on more recently for a subgroup sensitivity analysis. And I just want to point out down here, because they showed that in the subset of the 36% who got a recent vertebral fracture, again, teriparatide was much more efficient than risedronate in reducing subsequent fractures. The question out there for a long time regarding teriparatide has been whether it also decreased hip fractures. And because the trials were relatively small, there were relatively small numbers of hip fractures, not a single RCT with teriparatide had shown a specific reduction of hip fractures. However, we now have a recent meta-analysis of a bunch of trials with teriparatide, which collectively indicates that teriparatide potentially also reduces hip fractures, therefore adding to the evidence of the efficacy of this anabolic treatment. Now, in a sense, those are all drugs from the past because they've been out there for many years, and our look will go into the future with different drugs. But before that, because we're at Eular and you're rheumatologists, and because glucocorticoids is also a risk factor for fractures, and particularly when you introduce glucocorticoid therapy, it's a fracture for imminent vertebral fractures, I'd like to present to you the results recently published of the latest study in GIOP, which is a study that compared denosumab with risedronate in women who are either on glucocorticoids since quite some time or who initiate therapy. And this is a 2 years randomized controlled study. These are the women continuing glucocorticoids, 67 years old on average, already have some osteopenia. And these are the women that initiate glucocorticoids. On average, they're younger, and their bone density at baseline are pretty normal. Denosumab showed benefits over risedronate by increasing bone density at the spine and the hip, both in the group that was just starting glucocorticoids and in the group that was continuing glucocorticoids. Adverse events were well balanced between the two groups. Now, this is not a study powered for fractures, but fractures were recorded as adverse events, and there was no differences in the small fracture rate between the two groups. Nevertheless, based on an advantage in terms of bone density, now denosumab can be considered as another drug to potentially treat GIOP next to the bisphosphonates, next to teriparatide, which have been previously approved. So as I said, all these are drugs from the past in a sense, and what our eyes are looking to as drugs for the future. And the drug that everybody is hoping to see emerging soon is romosozumab. So romosozumab is a monoclonal antibody against sclerostin, and sclerostin is a potent inhibitor of bone formation. So contrarily to teriparatide and another of its derivatives not approved in Europe, romosozumab activates bone formation directly at the level of the bone-forming cells without increasing bone resorption. Actually, while it increasing de novo bone formation, it represses bone resorption. So a single antibody targeting a single molecule like SOST has a dual effect of both a bone-forming agent and an anti-resorptive. So major trials have been conducted, as you certainly know, with these drugs, one against placebo in low-risk women and one against alendronate in high risk, and both trials showed that romosozumab decreases vertebral fractures and clinical fractures as compared to both placebo and alendronate. Now, these trials were not just romosozumab. They were actually a sequence of drugs. And in the FRAME study, we treated women with osteoporosis and relatively moderate risk, first with romosozumab for 1 year, and then with denosumab for another year. And what we recently published here is the average gain of bone density, the absolute gain in T-score here at the hip with these 2 years of therapy. And you see that within just 2 years, the bone mass gained is equivalent to what we had previously achieved with 7 years of continuing denosumab, the anti-resorptive, alone. So the potential here to very much accelerate the recovery of bone mass. If you look at the reduction of fractures with this sequence of romosozumab and then denosumab, well, you will see, of course, that in year 1, romosozumab reduces vertebral fractures and clinical fractures. Through year 2, the advantage remains. But what's really interesting is here, because this shows you the fracture incidence in year 2 only, where all the patients received the same anti-resorptive denosumab. And what you see then is that those who previously received the bone-forming drug now have a rate of vertebral fractures and clinical fractures that remains lower than those receiving then the same drug but not previously treated. So this is a new concept in osteoporosis, that by hitting hard early on with a bone-forming agent, in this case romosozumab, you will regain bone strength, which benefits will not only be immediate during therapy, but will extend to the later period where you use a more common anti-resorptive. The same results have been seen in the other trial, where romosozumab was compared to alendronate, and then every patient continued on alendronate for another couple of years. And in every case, this sequence of romosozumab to alendronate proves superior in reducing fractures compared to alendronate alone for the same period. Again, fueling the concept that early reconstruction of bone mass and strength will have a carry-on effect over your period of anti-resorptive therapy. Now, what about monitoring the effects of therapy and taking decisions on long term? Well, for many years, and still today, I must say, in osteoporosis, contrarily to other chronic diseases, contrarily to RA, for example, the concept of treat to target was not existing in osteoporosis. We were using bone density to monitor the progress of our patients while using the drugs, but we had no concept that achieving a greater BMD gain or a greater absolute bone density could be useful, because we were lacking the data to demonstrate that bone density as a surrogate marker is a good marker to monitor the benefits of short and long-term therapy. This has changed through a couple of prominent publications. This very recent publication is a meta-regression that has included virtually every single trial in osteoporosis at the patient level. So there is about 100,000 patients in osteoporosis trials on this graph, and virtually every drug that has been ever tested in the disease has been taken care of. And what it shows to you is the relationship between the gain of bone density at the spine and the relative risk reduction of vertebral fractures. And you see it's a very nice inverse relationship whereby gaining more BMD at the spine explains 63% of vertebral fracture risk reduction. For the hip, increases in hip BMD across the trials also inversely correlates with the relative risk of hip fractures, so that gains in BMD at the hip explain nearly 50% of hip fracture risk reduction across the trials, and slightly less when we try to explain the overall effect on non-vertebral fractures. So the authors went on to show us that for example, a 6% gain of total hip BMD, there was a 66% reduction of vertebral fractures, a 40% reduction of hip fractures, and a 21% of non-vertebral fractures, whereas for smaller gains of hip BMD, there were smaller reductions in fractures. So definitely demonstrating that monitoring BMD every 2 to 3 years in a group of patients on any therapy would be a good indicator of the efficacy achieved in terms of fracture risk reduction. Now, this goes on in some long-term studies. This is the published study of the 10 years continuous denosumab. Hip BMD went up continuously for 9%, and those transitioning from placebo to denosumab, 7 years, they gained 7%. Now, more recently, we showed that while BMD goes up continuously for 10 years, the incidence of fracture further decreases in years 4 to 7 and then 4-10 of therapy compared to the first 3 years, indicating that the greater the BMD gain, the greater the reduction in fracture risk in these women. We also showed that the benefits of this long-term exposure to denosumab extends to women with T-scores both below and above -2, because both have a similar further fracture risk reduction in time. It extends to women with T-scores at the hip up to -1.5, because up to that level, after 3 years, if you continue treating, you still see a reduction in fractures. But for those who finally achieve a T-score above -1.5, then even if you continue therapy, you don't see any further reduction in fracture risk. And to put that in a different way, which is here, this is the relationship between the absolute bone density achieved at the hip on the course of therapy from 1 to 10 years, and the subsequent incidence of non-vertebral fractures. And you see very clearly that as you reach a density around -1.5, you have maximally reduced fracture risk, and by doing that, you have reached a so-called target for therapy, beyond which further treatment is probably not necessary. So these emerging concepts of using BMD changes, and even more so absolute bone densities in the course of therapy, have led some working groups to revise the concept of treat to target in osteoporosis. And this is, for example, the statement of the American Society of Volumetric Research working group on goal-directed therapy, whereby they now say that in patients at very high baseline risk, or patients above 70, the goal of therapy should be to increase the bone density, not just above -2.5, which is osteoporosis threshold, but higher, somewhere above -2. Now, talking about denosumab, the problem that has appeared is, of course, that since this is an antibody, once you start treating, contrary to bisphosphonates, it's not bound to the bone. So there is a so-called rebound effect in bone turnover and a rapid loss of bone density if you don't do anything else. And there has been case reports of patients who sustained new vertebral fractures and sometimes multiple vertebral fractures upon stopping denosumab. So we reviewed this question in the FREEDOM trial, focusing on 1,500 women who had stopped therapy, either placebo or denosumab, voluntarily in the course of the trial. So while they were on therapy, obviously, women on denosumab had fewer vertebral fractures than women on placebo. But as they went off therapy, in a very short time, which is just within a few months, the rate of vertebral fractures off denosumab went back to placebo levels. This is even worse in women at high risk, such as women who already carry a vertebral fracture. Again, on therapy, there is a vast benefit of denosumab over placebo. As they went off therapy, there is a large increase in the recurrence of vertebral fractures within a few months back to placebo levels. So this shows that with a treatment like an antibody, the benefits are quickly reversed, and therefore, once stopping this drug, there should be transition towards a consolidation therapy to maintain the benefits that have been acquired during denosumab therapy. There is no very good study so far showing what is the best drug to give after denosumab, but there is some small observations that have been published, and this is one of them. This is the follow-up of the FRAME trial, in which women received Ramos Oshima 1 year and then denosumab. So the gray bars indicate their bone densities in the initial trial, and then these women were transitioned to nothing, to risedronate, or to zoledronate. And what you see in the black bar is the residual benefits in terms of BMD. And it seems from that, at least, that after denosumab, if you give 1 or 2 infusions of zoledronic acid, you would better maintain the gain of bone densities that have been achieved before than if you give an oral bisphosphonate or nothing at all. There is a number of trials going on right now that are assessing the best timing of zoledronic acid infusion after denosumab in order to better preserve bone density, and some of the results will be presented later this year at the SBMR. So all things considered, in Switzerland at least, we quite recently released new guidelines for the long-term management of patients starting on any osteoporosis drug and for the long term. So for patients starting on bisphosphonates after 3 to 5 years, whether a patient falls now in the low-risk category, which would mean a BMD as good as possible, possibly above -2 T-score at the hip, and no more fractures. There is a possibility of some drug holidays for a couple of years, considering the remnants of the drug in the bone, provided you will reconsider BMD every couple of years and maybe use some bone turnover markers in between. For those remaining at high risk, which would encompass categories of patients with fragility fractures, patients who still have low bone densities, particularly below -2 if they're older, patients who remain on glucocorticoids, patients who remain on aromatase inhibitors. In that case, there is not much evidence for more benefits of bisphosphonates beyond 5 years, and we rather advise to switch to either teriparatide or to denosumab. In patients starting on denosumab for 4 or 5 years and falling in the low-risk category, as I said, there is no possibility to just stop, and it is advisable to consolidate with some bisphosphonates, particularly with IV Zol, for a year or 2. For those who remain high-risk, though, the 10 years data indicate continuous benefits on gaining BMD and decreasing fractures, so they could be kept on the same drug for as long as 10 years or more. And in case of desperate conditions like recurring bone fragility, there is some data suggesting that the addition of teriparatide to denosumab, not the switch, but the addition, could be beneficial in those patients as well. And at the very end, once again, there is no fragility fractures for a few years, and BMD will be nearly normal. Transition to a bisphosphonate would be advised. Now, the last part, very quickly, is to show you some recent data about potential benefits of osteoporosis therapy beyond osteoporosis, and I would like to focus on 2 things, basically, which is muscle, either heart or skeletal muscle. For many years, there has been questions about the potential harms or benefits of bisphosphonates on the cardiovascular system. And in particular, because of the nature of cardiovascular arteriosclerotic disease with arterial calcifications, bisphosphonates potentially could have provided some benefits, but have been hard to demonstrate. There is a very large observational study recently published in which patients with hip fractures were scrutinized for cardiovascular outcomes, whether they were on alendronate or not. And that study seems to indicate that with alendronate, there was a reduction in cardiovascular mortality, incident MI, and incident stroke, compared to those who did not receive the bisphosphonate. In parallel, in that famous study I showed you first of zoledronic acid every 18 months in low-risk older women without osteoporosis, in terms of adverse events, quite amazingly, there was a trend for a reduction in the rate of MI, in the rate of coronary artery revascularization, less so in stroke and composite vascular events, and also, by the way, a significant reduction in the rate of cancer, providing some, again, arguments for further benefits of this class of drug, bisphosphonates, beyond bone, potentially, to the cardiovascular system. Now, these data on the potential beneficial effects of bisphosphonates on the cardiovascular system are also important while trying to understand some data from the ARCH trial that compared romosozumab and alendronate. I showed you before that romosozumab clearly decreased fractures above and beyond alendronate in that trial. However, that trial gave a cardiovascular safety signal in which there were more cardiac and cerebrovascular events in the romosozumab group compared to alendronate. This was a strange observation because in the placebo-controlled trial of romosozumab, there was no cardiovascular signal. So the question rose whether or not this imbalance is due to some potential cardiovascular effects of Romo on high-risk women, or if it could be a beneficial effect of alendronate, as suggested by the previous observational trial that I talked to you about. So this is the reason why romosozumab has already been approved now in the US and in Japan, but not yet in Europe, and EMEA is still considering the benefits risk of these drugs before hopefully approving it. Finally, I'd like to draw your attention, I'm sorry for the little cocorico here, to a study that we recently published in JCI, in which we looked at the effects of denosumab on muscle. And the reason why we looked at that is because in the large randomized controlled trials of denosumab, the rank ligand antibody, there was not only a reduction in fractures, but a reduction in falls that so far remained unexplained. So what you see here in this sort of small preliminary observation of ours is that as compared to alendronate or placebo, women who received denosumab for 3 years not only gained more bone density as expected, but they gained significantly more appendicular lean mass and hand grip strength. And what we show in this paper through a bunch of experimental data in mice is that indeed inhibiting rank ligand has beneficial effect on muscle metabolism, therefore extending the potential benefits of this drug outside of bone to the muscular system as well. So to conclude, what's hot in osteoporosis 19, where we learn a number of things. We've learned that zoledronic acid reduces fracture risk even in women at low risk. On the other side of the spectrum, we've learned that anabolics, and particularly teriparatide and in the future romosozumab, are more efficient than oral bisphosphonates in reducing fractures in high risk. We've seen treatment sequences starting with anabolics, for example, in the romosozumab denosumab trial, that provide very large BMD gains in just a couple of years that compare to many, many years of a single antiresorptive and provide also a rapid risk reduction of fractures. We've seen, importantly, that BMD gain on therapy, and particularly the absolute level of bone density reached on therapy, is a good surrogate marker of the reduction in fracture risk, and in the future could be used as a treat-to-target approach and strategy. And finally, we've seen that treating osteoporosis, particularly with bisphosphonates or denosumab, could provide benefits that extend outside of the skeleton towards the cardiovascular or muscular system. With that, I'd like to thank you for your attention and remind you that you have to evaluate our sessions on your app. Thank you very much.
Thank you, Serge, for this outstanding presentation. And I see that there are many, many questions. So, number 2.
Thank you very much for this very interesting talk. Tom Stoll from Switzerland is my name. You spoke about the sequence of treatment with zoledronic acid following denosumab, and you didn't somehow touch the subject of atypical femoral fractures or of necrosis of the mandibula. So how long would you somehow treat totally these patients? How many years?
Okay, well, first of all, thank you for reminding me. I actually skipped the slide which is here. This is just to show you the rates of osteonecrosis of the jaw and atypical femoral fractures in the subjects exposed to denosumab, the most potent antiresorptive, for 10 years. You see that the rates are in the range of 0.05 per 100 patients for ONJ, 0.01 for AFF. So this recapitulates what has been seen in many other studies, including with bisphosphonates, that the risk about 1 in 10,000 after 5 to 10 years of therapy. There is a study that we've also presented in abstract form, but not yet published, where we calculated for 10 years of exposure to denosumab, what was the benefits-risk ratio, so how many fractures we spare for one case of a typical femoral fracture, and the ratio is 286. So yes, there is a very small risk with long-term therapy, but it remains very, very small.
Thank
you. Number 6.
Samuel Badawi, Egypt. Thank you very much, Serge. What about wrist fractures? Can they predict other fractures, like hip fractures, for example?
Wrist. You mean wrist? You said wrist fractures. Yes, yes, sure. I showed you in the beginning the study from Medicare. They looked at the initial fracture from vertebrae to hip pelvis down to even the ankle. Every fracture predicts the next fracture.
Number 5.
Well, I will touch upon a very basic question. It is well established that anti-resorptive and anabolic should not be used together. But now opinions are gaining ground of their use. Would you ever advocate to prescribe both of them together in any condition?
Well, as I said, there may be very severe osteoporosis cases with fractures and very low bone densities, whereby combination of therapy has a potential, particularly denosumab with Teriparatide. However, to be honest, the data we have is only in few patients, and it's based on gains of bone density, and we don't have fracture data. So I don't think we'll ever have real fracture data with combination therapy, but I have an a priori positive approach with combination high-risk patients.
Right, thank you. And
sorry, there are so many questions that you will be able to ask the question after the session. Thank you. Number 3.
Further, Zurich, I have a question at alendronate and cardiovascular system. There is also the discussion with the calcium. Is that benefit or not for cardiovascular events? Now, in these studies, can you separate between the alendronate effect and the calcium?
Okay, well, the observational study I showed to you did not include calcium. As you know, this is a very controversial issue. The adverse cardiovascular effects of calcium supplementation are not uniformly or universally proven, particularly not when administered in patients with low baseline calcium intake.
Thank you.
So, Osama Haidgi from Egypt, based on the sequential therapy concept that will be the future, and based that anti-fracture data is confirmed with a placebo period of time, why not to restrict the medication to the duration of the original approved trial? It means 3 years for bisphosphonate, 2 years for teriparatide, 1 year for Ramos Oshima.
Well, there are drugs which duration of use will be constrained by the design of the original study. that is why we can only use a Teriparatide for 2 years. We'll be using Romo if it comes for 1 year, like it's in the US now, etc. But for other drugs like denosumab and alendronate or zoledronate, there have been extension studies that have shown the extended benefits beyond the 3 years of randomized control study, and that is why we can use those drugs longer.
Thank you.
Number 8.
Thank you very much. Gabor Major from Australia. Thank you. Over here. I would like to ask you a comment. I would like to ask you to comment about the treated target of -1.5, and how would you reconcile that with the Ian Reid results that treating people with even -1.5 is worthwhile?
No, absolutely. So we need to distinguish the indication for therapy at baseline and the benefits of monitoring the treatment. Probably that if you continue to treat above -1.5, you will still have some benefits, but they become smaller and smaller. I mean, what I did not comment in the Reid study, of course, is that the number needed to treat is extremely high, because by treating women at low risk, you have very few events. So even though treating above -1.5 continuously, there could probably still be some additional benefits. I doubt that the benefits-risk ratio, as we discussed before, or the cost effectiveness will be proven unless we use then very, very cheap drugs.
Thank you.
Number 3.
I just wonder, in one case, a woman having a treatment with denosumab, can't you use at the same time an ONT inhibitor for osteoarthritis?
So yes, there's been a phase 2 study, and there is a number of observational studies published showing that denosumab administered concomitantly to a biologic for RA does not increase the risk of infectious disease, and as you know, has some potential benefits on the subchondral erosions.
Okay, thank you.
Number 2.
Thank you for presentation. Branko Barac, Serbia. Just want to ask you how long we should treat patients, especially with oral bisphosphonate alendronate. Is it 5 years? Is it written in some guidelines, especially when we are looking at positive effects on cardiovascular system, or longer, and what after?
So like I said, the current guidelines recommend maximum 5 years for oral bisphosphonates, 3 years for IV, unless the risk remains high, in which case treatment could be extended. But I personally, and our Swiss guidelines say, it's better at that time to switch to another agent, either denosumab or teriparatide if needed, in terms of benefits, rather than just keeping them on bisphosphonates for much longer.
Thank you.
Number 3.
Yeah. Thank you for your presentation, Dr. Ibrahim from Qatar. My question is, any data about bone marker use at the target point for osteoporosis?
Thank you for the question. So, bone turnover markers are very useful in monitoring the efficacy of therapy, and the same meta-regression that I've shown to you is gaining BMD has been shown to some extent with CTX or other bone turnover markers. So reducing bone turnover markers more with anti-resorptives means gaining more bone density and reducing fracture further. So they can be used to monitor the efficacy of therapy to a certain extent.
Hi, thank you. Just you might be answered this, but I couldn't hear. Dr. Sahar from the UK. Just very 2 quick questions. After you've given like a year or 2 of the IV bisphosphonate for the denosumab patients, then what do you do? Do you just monitor, or do you go back to denosumab?
So say again, I'm not sure.
So after you've given your 5 or 10 years of denosumab,
then you give all.
Then you've given your 2 years of bisphosphonate.
So I strongly, considering how little we know right now, and before we see the trials that are examining the right time and right dosing of ZOL, I strongly suggest to monitor bone turnover markers in the course of ZOL after denosumab and for at least a couple of years, just to make sure that the bone turnover remains controlled.
Fine. And just
and by the way, to monitor them often, which is at least every 3 months.
Every 3 months off?
At least.
And you do that over monitoring the T-scores?
Couple of years and across the range of T-scores. It's independent of that.
Okay. And just very little question, the AF risk with IV bisphosphonates, do you think that is not a risk now, or? risk of atrial fibrillation?
No, that has not been confirmed.
Not confirmed. No. Fine, great. Thank you.
Thank you very much, Serge. And thank you for your active session with many, many questions. Thank you.